This is Oral Rehab Lecture 6, Part 4, the last component, the last part of Lecture 6 on disability and disability considerations. Again, picking up here approximately slide 22 from your slide set. So the idea of hearing problems has also been described elsewhere as going beyond the audiogram. Again, the dilemma is, as we've seen, is that in America anyway, is that the notion of disability is typically measured based on audiometric test results. And we already said that the audiogram alone is going to be very poor at predicting a lot of things, and in an individual, generally said, poor at predicting hearing problems. So we're sort of at a philosophical chasm here in terms of, well, what do we do about this? But the notion of going beyond the audiogram is an interesting way of sort of describing this, which is to say the audiogram is not enough. In oral rehab specifically, the audiogram is not enough. We need to know more about the person. So what are some typical ways of going beyond the audiogram? How do we do these kinds of assessments? Well, traditionally people have done interviews, which include case histories that might have more questions and other questions. There has been over the last 40 years at least, maybe even going back to, or a little bit earlier, 50 years maybe, there have been a number of questionnaires that have been developed to assess persons' hearing problems. Sometimes these are referred to as inventories. That just simply means that there's a lot of questions. They may be divided into different sort of topical areas, and that is to say that they cover multiple topical areas. And that's just sort of what the general sense of an inventory is. Additionally, you could either request or not commonly, but patients will sort of sometimes arrive with a daily log or a journal of their problems. Someone that is taking that much care and attention about describing their sort of day-to-day life and has that kind of attention to detail is someone that needs to be considered very carefully. Because likely they're going to be making those notes about you too. So just saying. All right. So all of these things are, and particularly as we'll see as we get into the hearing aid stuff, the use of questionnaires, which is to say different kinds of, again, formal subjective measures to get at persons' perceptions of their problems, is something that has been encouraged and is a very contemporary aspect of best practices. So that's sort of where the profession, if I had to say, is kind of trending toward, for a variety of reasons. So despite the good reasons for doing these, we're still left with the issue that probably across all audiologists and all persons who fit hearing aids, they're probably still not that widely used. And there's a number of reasons have always been implicated for this. There's really a lot of them around. One of the issues has been, well, none of them really covers all of the problems and all of the domains of problems that an individual might have, and that may be true to a certain extent, but that may be just not quite as correct as it used to be. Still, in all, you have the problem of, well, how does an individual decide which one to use? So that's a general problem. The issue is, well, then, okay, even if I do one, how does this flow into a rehabilitation plan? And again, that's not exactly seamless either. Audiologists have traditionally felt the need not to do them, which is just outright arrogant and lazy. So I don't have any excuse for that exactly. I can sort of relate that I understand it. But so to some extent, though, what we're talking about really fundamentally is that these things need to be made sort of user-friendly and have sort of a way that they could sort of lead to greater applicability. And that's sort of a challenge for audiologists and researchers right now, is to sort of how can we do this and do it better. As I've already said to you, there's some difficulties in assessing hearing problems. Studies have shown, over the decades that I'm been monitoring this stuff, that there's no explicit correlation between one person's audiometric results and their perception of their problems. I don't know, I don't recall that I have any specific articles on this point for you, but there's any of a number of articles that would, support that point. In addition, communication difficulties are going to vary significantly based on the individual setting that they're communicating in, their situation, their partner, the communication topic, their degree of assertiveness, their degree of benefit from their whatever therapies or hearing aid that they have. For some individuals, hearing difficulties don't always occur. And again, there's no single measure which predictably covers all aspects or all problem areas. And of the measures that I said, many measures that exist, one of the other criticisms is that the questions on that measure, on that test, on that questionnaire, like the SAC, may not be specific to that individual. In other words, it may be 10 really good questions that are really good for the average person with hearing impairment, but for this one person you're giving it to, it has really no applicability because it doesn't align with their lives and their specific problems. So, again, given the difficulties here and the inertia that we have to deal with, why should we do it? Well, we can use assessments of hearing problems as a screening tool to indicate who might be much better suited for oral rehabilitation than compared to others. You can use it instead in an oral rehab context instead of a case history measure. Even though it may be difficult, you can use it to plan rehabilitation. So if you know that a person states that they've got the following problems, well, that's going to align, it seems to me, pretty easily with, okay, well, we need to work on how you're going to do better in those particular circumstances so you don't have those particular problems. You can use these as an outcome measure. And as I said to you, the notion of measurement of outcomes, as we're going to see very, very shortly, turns out to be a very important part of what we call best practices in hearing aid fitting. Again, the problem is not everybody does these, but best practices and even the data support that this is something that's very, very useful. The kind of things that we're going to want to measure as an outcome measure, the outcome of treatment, and in this case, I'm focally thinking of the outcome following hearing aid fitting, would be benefit. Are you better with it than without it? Satisfied? Do you feel that the cost and all of the difficulty that it took you to get this product is worth the benefits that you're getting? And is there an improvement in the quality of life? We've already dealt with quality of life as something that needs to be measured. Perhaps someday these things will be considered in determination of disability, only because if we want to think globally, disability really is this notion of the kinds of activity limitations and participation restrictions you have. And therefore, instead of using an audiogram to assess disability here in America, we should be using some kind of self-assessment inventory. As I pointed out to you, there's a lot of these available actually, and they cover some specific areas that are kind of beyond us for the moment. But just because I said I will do another unit on this later on. But the non-audiologic, the non-hearing impairment domains include the person's perception of how well they understand speech in certain circumstances, the person's perception of how other people behave and react around them, the person's statements or affirmation of the kinds of emotional reactions and attitudes they have. It also will ask for non-speech problems. Are you able to hear car horns? Are you able to hear alarms? Or that sort of stuff. And the perception and occurrence of related problems, primarily something called tinnitus, or the perception of a sound in your ear when there's no sound present in the environment. That's often a co-occurrence with many hearing impairments. One example that's a good one because it's your authors of your book are also authors of a self-assessment inventory, and one that's been around a long time, which is called the Self-Assessment of Communication, or SAC. It has 10 questions. The next page I've got, the next slide rather, I've got You might not be able to see it on this screencast, but in your printout version, you can probably isolate that one and blow it up and look at it. The older version of that had 10 questions. The revised version has somewhat more. The revised SAC from approximately 2003 is in your text at page 406. And page 496, they provide a text. In the text, in their cases, they show an example of where how it's appropriately used. They wrote, was kind of clever, something called the SOAK, which is a companion scale, which is self-assessment of communication by the significant other assessment of communication. And so it provides a perspective of the person's communication partner or whoever their significant other is. If you use this as an outcome measure, you'd do SAC before the hearing aid, and you do a SAC after they've been fit with the hearing aid. Yeah, I can read that on my screen, but you may not be able to read it there. And if you go through this, the original SAC from 1982, what you'll see is, and I'm not going to ask you this, but you'll see that many of these are activity limitations, and some of these are participation restrictions. So some of these also deal with feeling issues as well. So in this particular inventory, you'll see that there's some things that relate to emotional information about others and so on. But most of these sort of items 1 through 6 are primarily activity limitations, and I'll let you look at that on your own at some point. But mostly look at the one in the book, which is an updated version of this. Now, interestingly, or not, I was part of the project that I had presented to you in an earlier slide set. We had done some preliminary work with, and so here's some people. Here's a name you might recognize from earlier article, Dennis Van Vliet. Van Vliet and Beyer worked for the American hearing aid company, or not a hearing aid company, but a hearing aid distribution company called Hear USA, also known in California as HearX. So in California, there's a company, and they're still around, Hear, and then with an X on the end, like prescription. Van Vliet doesn't work for them anymore. He works for Starkey Laboratories. Beyer still does. Ivory, that's me. So what we ended up doing here, this was kind of a pilot study for this study that we did a couple years later, was looking at pre-post treatment of hearing aids as business persons representing this company. Van Vliet and Beyer were interested in providing data to purchasers of medical and hearing aid benefits, so insurance companies and other institutions that were working on behalf of people with hearing impairment, to be able to provide data that shows that hearing aids help people, basically, that there's a benefit to this. So they used a revised version of the SAC called the SAC-HX to sort of represent HearX, so the SAC-HX. And so what you see here is data across the next couple slides have some data on this. Generally said with the SAC, as you'll see on the next slide, the higher the score, the poorer you are, not financially, but the higher the score, the more problems that you have and the more severity of those problems. In this particular slide, we're looking at basically 3 different groups. And again, they align this way. So 3 different groups: persons that had a satisfactory experience with their hearing aids, persons that had no experience with hearing aids, and persons who had an unsatisfactory experience. Basically, the nature of the task was to give them the SAC before, that's this pre-SAC measure, and then to give them the SAC afterwards, that's the post-SAC. So the pre-SAC is this kind of purplish color, the post-SAC is this maroonish color. And the idea is if there's been a reduction in their activity limitations and a reduction in their participation restrictions, their SAC score should get better. And in fact, what you're seeing here, this just denotes right ear hearing aid and right ear, left ear. So you could actually aggregate these two, but you can see there's not much difference across right and left. Basically, despite the level of satisfaction that a person had with their hearing aids, their SAC scores all got better. And again, we see that across all three of these groups, that there is and as it turns out, a statistically significant difference between their performance without the hearing aid and their performance with the hearing aid. And that was true across these three groups. And while not remarkable, it was good to note that and to provide data for that point. This is out of your book, actually, and it's just simply the categories of the SAC, showing the bigger the number, the sort of the more problems that an individual would have. Here's another slide from that Van Vliet, Beyer, and Ivory thing that we did. In this sense, here we're looking at just simply aggregating everybody into groups. I'll take just a second to explain this. Again, the purple is pre-SAC. So in this particular group, there was not as many persons. The number here is only about 200 to 250 as compared to the 4,500 we did in the later analysis. And so what we're saying here is that the purple scores were what people said of these 200, how many of the 200 felt that they had severe problems based on the SAC score. And again, the majority of them, the biggest score was in the severe range. And you could see that that's true for, as there's less and less sort of closer to normal functions of all these individuals. After the same group was fit with hearing aids, there was almost 100% reversal of their SAC scores, meaning that now most of the people now had their SAC score within normal limits. And then again, very few. So again, if we look at pre-SAC, the trend's like that, in the sense of most people have a lot of problems. Now we look at it post-SAC, post-hearing aid SAC, most of their problems have been resolved, to which they're either normal or slight. Some people residually still exist as having some problems, but essentially this was data that was interpreted to say that look at the benefit that people get from hearing aids, and essentially we're saying is that 86% of this pool reported that they were much better with the hearing aids. Fundamentally, that's the interpretation. There's another way to do this kind of assessment. Your authors provided as well a measure called the COSI, Client-Oriented Scale of Improvement. This gets at the issue that where the individual actually lists their problems, and then you can work or prioritize them. So this is highly individualized. So you say, what are the 5 main problems you have, and the person writes them out. This can be used as an outcome measure, because then after they have been fit with hearing aids, then you say, okay, well, how much better are you now for these 5 problems? The basic benefit of the COSI is that it's highly individualized, so it's for the individual. Okay, so our last slide here in this group, again, just kind of tries to wrap up what are some of the outcomes of application of these self-assessments. To try to get at what an individual's problems are, to try to provide data that can be used as a baseline for comparisons, especially comparing against treatments. And additionally, these kinds of data, particularly at sort of the intake level of work, could end up with sort of a categorization of the person. You can look at the page 24 in your book that looks at part of a model which categorizes people as type 1, 2, 3, or 4, and this sort of talks about their basic readiness to proceed into oral rehab. This is useful to inform us about whether or not they're a good candidate for hearing aids and for oral rehab. And the final point here is that simply going through this kind of assessment probably helps to reduce denial. If you have that SAC versus SOAK, and then you contrast those, then it makes very explicit, okay, the guy's saying, no, I don't really have many problems, and then his significant other is saying, oh, yes, you do. You have a lot of problems. So there's certainly benefit to that. Okay, with that, we conclude slide set 6.